Hello everyone. Myself, Dr. Forhad Akhtar Zaman. I'm additional professor and HOD of Community and Family Medicine and Associate Dean Academics, All India Institute of Medical Science, Guwahati. So my greetings to you and welcome to the UZ eConnect. Today my topic for discussion is journey towards tuberculosis elimination in India. So if you see the basics of tuberculosis, it is one of the oldest disease of humankind caused by Mycobacterium tuberculosis, and it mainly affects the lung. Although it can affect many other organs of the body, be it skin, intestine, or the CNS, mainly the meninges, or the urinogenitory system, the pleura, the pericardia, the musculoskeletal system. So those are known as the extrapulmonary tuberculosis. And if properly treated, it can be cured. And if untreated, 75% of the TB cases may die within 5 years. The drug-resistant TB is a new menace that has come up, and one-third of the world is estimated to have latent TB infection. If you see the death from infectious disease in the last 200 years, we can see that tuberculosis, it occupies the major chunk and it is much larger as compared to the killer disease of smallpox, which has been eradicated. Malaria, plague, influenza, cholera, or the modern epidemic of HIV/AIDS, and even the recently concluded pandemic of COVID. And this is the top causes of death worldwide in the year 2019. We know that the non-communicable disease are the major killer in the world nowadays. And you can see the ischemic heart disease, stroke, COPDs, they are the major killer. And if you see the infectious disease, there is the lower respiratory infections or the diarrheal disease, but mainly they are affecting the under 5 children. Among the adult, among infectious disease, tuberculosis is a major killer, which you can find from this graph. So total 10 million people affected by tuberculosis all over the globe, of which 1.2 million are having HIV associated with TB, and 132,000 almost are having the drug-resistant tuberculosis. So the problematic area is the Southeast Asian region where almost 46% of the global burden is there, followed by Africa of 26%. And it is noteworthy that India alone harbors about 26% of the global tuberculosis load. And you can see those are the 6 countries: India, Pakistan, China, Indonesia, and Nigeria. The incidence of TB in case of Africa, it is about 280 per 100,000 population. In India, it is more or less about 200 per 100,000 population. So this is the WHO NTB strategy. We know we are going to, we have set a target of eliminating TB by the year 2025 in India, which is 5 years ahead of the global target, SDG target of 2030. And if we see the global projection to 2035 compared with the current trend, there is a current global decline in the tuberculosis incidence by about 2 to 3%, and which is very much true for India also. And if we continue with this trend, with this decline, then by the year, leave about 2025, 30 or 35, even in 2050, we will be nowhere near eliminating tuberculosis. So we need to optimize the current tool. We need to introduce a new tool in the form of vaccination, in the form of latent TB infection management. So something we need to do to bend the curve so that we can eliminate TB by 2025 to 2035. That is the global target. India is 2025. If we see the TB control evolution, It started in 1951 with the BCG campaign. Then in the year 1956, the Tuberculosis Research Institute, which is now known as the NIRT, National Institute of Research in Tuberculosis, Chennai, was established, where the domiciliary treatment sanatorium approach was started. Then in the year 1962, the National TB program, it started. It was an era of longer regimen, and the mass miniature radiography. X-ray was the main modality for diagnosis. Then there was another problem that there was a discontinuation of drug due to unavailability of drugs in between the treatment. The treatment has to be stopped because of unavailability of the drug, or there was a discontinuance of the treatment. Then came the era of the short course chemotherapy and the DOTS in 1993, and finally in the year 1997, the revised National Tuberculosis Control Program was rolled out, with the basic changes in the form of directly observed short course chemotherapy, then patient-wise box, which made sure that once a patient is enrolled and has started treatment, there is no question that he will ever run out of drugs, because that box is for that patient only. And the modality of diagnosis, it changed from X-ray to sputum microscopy, which is more sensitive. And X-ray is also there, but sputum microscopy became the main mainstay of the diagnosis. And towards 2017-18, we had introduced molecular diagnostics in the form of NAT, CBNAT, and TrueNAT, which has caused a revolution in the whole concept of tuberculosis diagnosis and control. And the year 2019, the National Tuberculosis Elimination Program was launched. It was not just a change in the name. There are a lot of changes that we'll see later. So I have already discussed how the NTP program started in 1962 with BCG vaccine, domiciliary treatment, long course chemotherapy. It started with. Then we have already discussed the RNTCP with dots, smear microscopy, patient-wise box, strengthening the drug supply. So that was the mainstay of RNTCP when it was rolled out in the year 1997. Then we had the National Strategic Plan in phase 1 in 2012 to 16, where TB notification was made mandatory even from the private sector. Then there was a complete geographical coverage for drug-resistant TB. Serodiagnosis was banned by Government of India. And to create a database for TB, Nikshay portal was launched, which was then only a web-based application, but now it is both a web-based and a app-based application. You can download the app and you can also notify tubercular patient, provided that you have got the login credential. Then there was something called Standards for TB Care in India, which was published in 2014. And this was the base on which many things got changed subsequently, in the form of the intermittent treatment to daily dots, fixed dose combination. So this standards for TB care was the base in which many things got changed in the erstwhile RNTCP and also the NTEP. Then the NTI Bangalore conducted the first and the largest national drug resistance survey in the year 2016-17. Then came the National Strategic Plan 2, 2017 to 25, which is still continuing. It is incorporated based on 4 strategic pillars, that is the detect, treat, prevent, and build, that we'll discuss one by one in brief. So in Detect, we have got the new initiative of active case finding. We know that tuberculosis had no active screening methods. It was a passive case finding where the presumptive TB cases, which were earlier known as the TB suspect with cough and fever, used to report. Then they used to be sent for sputum microscopy to ultimately either detect tuberculosis or declare as not suffering from tuberculosis. But the active case finding among the vulnerable high risk group, like among the diabetics, among the old age people, among the migrant laborers, slum dwellers. So those are the high risk groups where this concept of ACF was introduced, and it yielded so many hidden cases of tuberculosis from the vulnerable group. Then for early diagnosis and treatment, there was a rapid expansion of microscopy center, and also introduction of the fluorescent microscopy, which was more sensitive, and also the scaling up of molecular diagnostics. I mean the NAT test in the form of TrueNAT or CVNAT. So even rifampicin sensitive cases are to be tested for INH monoresistance. And universal DST, it has become a norm. Now, anyone who is diagnosed to be tuberculosis, either clinically or through microscope, before putting into treatment, they have to undergo the NAT test, either CBNAT or TrueNAT, to know the status of rifampicin resistance. So if it comes to be rifampicin sensitive, then we go for the drug sensitive TB treatment regimen. Now we don't have category 1, category 2, category 3. Category 3 was phased out some 10, 15 years, 10 years before. Even category 2 was phased out about some 5 years ago. Now we are having only drug sensitive TB treatment regimen and drug resistant TB treatment regimen. So even if it is RIF sensitive, the other sample is sent for the line probe assay LPA, first line LPA, to know the resistance pattern for INH. And if it comes out to be rifampicin resistance, then we go for the second line LPA and ultimately the culture sensitivity, liquid culture, to know the pattern of resistance among the second line drugs. And accordingly, we decide on something called individualized treatment protocol. So the treatment and management of tuberculosis has come closer to something we call precision medicine. It is not based on assumption, but on more precise and tailor-made for individual. So we can call it individualized treatment protocol rather than something like category 1 or category 3 or 3, which used to exist earlier. Then many sorts of incentives are given for the treatment supporter, for the informant, so that more and more cases are reported. Then in treatment, the daily dose from intermittent to daily therapy, that we call daily dots, and also the fixed dose combination started way back in 2016 with a pilot in 4 states. Then it was rolled out for the whole country after training. And injection-free regimen, which is revolutionized. It has a empathy, because you can imagine the mainly the drug resistant TB cases with the injection being given on a daily basis for 9 months, 6 months. You can imagine the pain that the patient had to endure. So the whole regimen of drug-sensitive TB, which had only one injection, that was streptomycin, and drug-resistant TB, which had more than 2, 3 injection amikacin, kanamycin, capreomycin. So all those were phased out. Now it is a total injection-free regimen, both drug-sensitive and also drug-resistant. So then we have got the Nikshay Poshan Yojana, because malnutrition is related to decreased immunity, which is related to flaring up of the tuberculosis from latent to active TB. So 500 rupees per month is being given through Aadhaar linked PFMS system directly deposited to the bank account of the beneficiary, and it is expected that the beneficiary will buy nutritious food. And there is a ICT based treatment adherence monitoring. Earlier we had the senior treatment supervisor. We used to supervise or monitor the treatment adherence. But now with the daily dots, it has become very difficult. So we are using the communication technology like 99 dots or missed call or SMS reminders. Then in the prevention, airborne infection control, then contact tracing of the diagnosed cases, contact tracing of the diagnosed cases, it has come up in a big way in the form of PMTPT, that is programmatic management of TB preventive therapy, where all the household contacts they are traced of every smear positive pulmonary case, household close contact. They're traced. Then they are screened to rule out active TB. And once they are ruled out of active TB, they are being provided the TB preventive therapy for less than 5 years. They are being provided with either 6 months of daily isoniazid 10 milligram per kilo body weight, which amounts to about 180 doses, or a newer regimen which is going to start very soon and which is going to be easy. So far as compliance is concerned, because it is only a 12 dose schedule. That is 3HT, 3 months, once a week, that is 4 doses per month for 3 months, it accounts to 12 doses. 3HT means isoniazid with rifampicin, and very soon Government of India will make it available for the TB preventive therapy. So below 5 years, there is no test and treat policy, but above 5 years, there is something called test and treat policy, where we first, after ruling out active tuberculosis, we also rule out whether the person is suffering from, whether the person is harboring latent TB or not. So we do either TST or IGRA test to know if TST and IGRA is positive. We go for the TB preventive therapy for above 5 years. Below 5, there is no test and treat policy. Directly we administer the TPT. But above 5, if only positive for IGRA or TST, we go for TPT, and if negative, we do not go for TPT. Let me tell you that TST or tuberculin skin test, it is less sensitive because of the universal BCG use. There are a lot of false positive. So we are moving from TST to IGRA. The problem with IGRA is that it is resource intensive and also costly. So very soon we will have another test that is called CYTB, 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 which is a skin test. So we will get very quick result, and it is also not that costly, and it is not resource intensive. So very soon, within another 6 months, we are going to have this test. But whether tested or not, TPT has to be started even for above 5 years. If you are not having IGRA facility is not there everywhere. So if you are not having IGRA also, we can go ahead with either 6H or 3HP, which is going to be available very soon. Then programmatic management of tuberculosis, preventive treatment in India. Already I have spoken a lot about that. Then under the build component or strategy, translate high-level political commitment to continue. Then restructuring NTP management structure, scale up technical assistance, and align partners activity with the program need. Now, before ending, let me tell about the latest initiative under NTP in a nutshell. National TB Prevalence Survey, which is the world's largest survey only of its kind. It was done to know the TB prevalence in 20 states using IGRA. Then paradigm shift in management of drug-resistant TB. We know that the injectable were phased out. We are having injection-free regimen, and with the introduction of bedaquiline and delamanide, the regimen has become shorter. So drug-resistant TB, we are having the shorter regimen, and also we are having the longer regimen who are not eligible for the shorter DRTB regimen. Then latent TB infection management, already I have spoken in details regarding this. This will be the key for bending the curve. Without this, it is very difficult. It is very difficult unless and until we are having a effective new vaccine even for the adult. And let me tell you, this latent TB infection management, it has started with the close household contact of the smear positive pulmonary TB. It has started with that, but we are ultimately targeting even the workplace contact and up to the general population. The general population, you, me, among us, 30% of us are already infected. We are having latent TB. So we will also be targeted. That is the ultimate aim. It has started with the household contact. Then lastly, Pradhan Mantri TB Mukt Bharat Abhiyan. It is an effort to engage the community to for community participation, which we call Jan Bhagidari, where each member of the community, common citizen like you and me, or organized sector can adopt TB patient and support them for nutrition for 6 months. So I myself is also a Nikshay Mitra, and I will encourage each one of us to adopt at least one TB patient to become a Nikshay Mitra. It hardly costs from rupees 500 to 800 based on the food items that you are giving per month for 6 months. So, concluding, we have come up a long way in curbing TB, but still had to do a lot of work. The challenges still remains in reaching the unreached and management in hard to reach area, urban slums, migrants, and the huge reservoir of latent TB infection is another challenge which has been taken up by the program in the form of managing the household contacts, starting from there, and ultimately we are aiming for the latent TB among the general population, management of latent TB among the general population. Then strengthening quality care in private sector. Good news is there that the private sector, which used to be aloof from the program, now they are participating. They are notifying the patient, and the notification has gone up to 60-70%. And looking forward, newer strategies like latent TB, infection management, BPAL regimen, that is for the drug-resistant TB, seems to be the hope to achieve our end TB target by 2025. So we all hope that together we'll end TB by the year 2025. Thank you. Thank you so much. So at the end, I would like to acknowledge the eConnect team led by Dr. Himasri Bhattacharya, Associate Professor from AIIMS Guwahati, the other eConnect team, and all the patrons of our national team from Indian Association of Preventive and Social Medicine. So I would like to thank IAPSM and the UZ Connecting team to have given me this opportunity. Thank you. Thank you so much.